Echocardiogram in apical four-chamber view demonstrates prolapse of both anterior and posterior mitral leaflets marked by arrows. The central part of the leaflets can be seen more towards the left atrium than the coaptation point. Mosaic color Doppler jet of mitral regurgitation can be seen in the left atrium starting from the mitral valve. Severity of mitral regurgitation can be estimated by comparing the mitral regurgitation jet area with that of the left atrium. Higher the ratio of MR jet to left atrium, the higher the severity of mitral regurgitation. American Society of Echocardiography and European Association of Echocardiography suggests that color Doppler jet assessment should be used only for the diagnosis of mitral regurgitation and not for exact quantification. This is because the color Doppler jet method is not excellent for quantification, though it will not be erroneous at both extremes in the trivial and severe situations. Another method is by measuring the width of vena contracta. Vena contracta can be measured in multiple planes. Biplane vena contracta gives a better correlation with regurgitant volumes. Biplane vena contracta width of 0.5 cm or more indicates a regurgitant volume of more than 60 ml and corresponds to regurgitant orifice of more than 0.4 square centimeter. Vena contracta is the narrowest portion of the MR jet at or just beyond the regurgitant orifice. It is an accurate indicator of severity of MR, but being a small absolute value, measurement errors can be magnified. Vena contracta gives an estimate of the effective regurgitant orifice. This is best measured in the parasternal long axis view. In apical four-chamber view, usually the inherent limitation of lateral resolution makes measurement of vena contracta erroneous. Vena contracta is measured in a view with the ultrasound beam perpendicular to the flow. In certain eccentric mitral regurgitation jets, it may be measured well in the apical four-chamber view. A zoomed image visualizing the proximal flow convergence, the vena contracta, and the downstream flow jet is needed for the measurement. In severe mitral regurgitation, the vena contracta usually measures 7 mm or more. Values less than 3 mm excludes severe mitral regurgitation. Intermediate values need other methods of quantification for verification, like proximal isovelocity surface area or PISA method. Regurgitant volumes can be calculated using pulse Doppler at mitral annulus and left ventricular outflow tract. Velocity time integral at each site multiplied by the area by planimetry gives the flow. Difference in the flow volumes between mitral and left ventricular outflow tract is a measure of the regurgitant volume. Regurgitant volume divided by the velocity time integral of the MR jet will give the effective regurgitant orifice. Echocardiogram in apical two-chamber view demonstrates the prolapse of both anterior and posterior leaflets as well as the color jet of mitral regurgitation. Scallops of the mitral leaflets are also visible on close scrutiny. Identifying the scallops involved is useful during surgical repair of the mitral valve. This is better achieved by transesophageal echocardiography, especially with real-time three-dimensional imaging. 3D imaging can give a surgeon's view of the mitral valve from both the ventricular and atrial aspects. Anterior leaflet has three divisions named A1, A2 and A3. Posterior leaflet has three scallops named P1, P2 and P3. Since P1 scallop is near the anterolateral commissure, it is known as the anterolateral scallop. P3 is near the posteromedial commissure and is known as posteromedial scallop. P2 is known as the central scallop. Here are a couple of journal references. Carpentier Nomenclature of Mitral Leaflet Scallops. Carpentier nomenclature of mitral leaflet scallops is important in assessing the mitral leaflets while planning mitral valve repair. The scallops can be identified well by transesophageal echocardiography, preferably in three-dimensional mode. Two indentations in the posterior leaflet divides it into three independently mobile scallops named P1, P2 and P3. Anterior leaflet is non-indented but has been divided into three corresponding virtual subdivisions known as A1, A2 and A3. Normal mitral valve in parasternal short axis view. RV right ventricle, IVS interventricular septum, AML anterior mitral leaflet, PML posterior mitral leaflet, LVPWO left ventricular posterior valve. Two indentations and three scallops of posterior mitral leaflet are seen. Posterior leaflet has a quadrangular shape while the anterior leaflet has semicircular shape. These can be visualized well by a magnified three-dimensional echocardiographic image. Systolic billowing of the mitral leaflets into the left atrium is rather uniform with an exception of P1 and P2 region. P1 has a single focus of regional heterogeneity in the curvature while P2 has two large foci of heterogeneity in curvature. This may be the reason why these two segments, that is P1 and P2, have a higher propensity for prolapse and becoming flail. Professor Alain Carpentier was one of the pioneers in mitral valve repair who introduced the nomenclature of mitral scallops. Here are some relevant journal references.